Good afternoon, everyone. Thank you for joining today's webinar, Expanding Access to Hepatitis B Vaccination. My name is Catherine Freeland, and I'm the Public Health Program Director at the Hepatitis B Foundation. We are here today because hepatitis B is a significant burden in many underserved communities. In the United States alone, recent literature shows that up to 2.4 million people are chronically infected with hepatitis B. Hepatitis B is vaccine preventable, and the hepatitis B vaccine was the first anti-cancer vaccine ever created. In efforts to continue to promote and expand hepatitis B vaccination access, the Hepatitis B Foundation and Hep B United are pleased to welcome our expert speaker to share strategies and best practices. For your knowledge, Hep B United is a national coalition co-led by APCHO and dedicated to promoting awareness, testing, vaccination, and linkage to care for communities most affected by hepatitis B. If you're interested in learning more about Hep B United, please do not hesitate to reach out through our website for tools, resources, and best practices at www.hepbunited.org. For your reference, here's a bit of housekeeping for today's session. As an attendee, you are in listen-only mode. You can interact with the panelists and organizers today by typing in the chat box or question box, as shown here on the slide. We encourage you to do this throughout the session. There will be time allocated at the end of the session for questions, and the call-in numbers listed for the U.S. are on this slide. At this time, I have the privilege of introducing our esteemed speaker, Dr. Wang, who is an infectious disease physician at Virginia Mason Medical Center in Seattle, Washington, and associate clinical professor of medicine at the University of Washington. She attended Northwestern University Medical School and completed a fellowship in infectious disease at the University of Washington. Her research and professional interests include chronic viral infections, including hepatitis B, hepatitis C, and HIV. For the past 20 years, she's also worked 2 days a month at the International District Medical Clinic, a federally qualified health center serving predominantly immigrant populations, including immigrants from China, Vietnam, Russia, and sub-Saharan Africa. She's published numerous papers on the epidemiology and treatment of chronic hepatitis B and hepatitis C, including a study on improving hepatitis B vaccination rates, which will be, I'm sure, discussed or highlighted within this session a bit. So at this time, I'd like to turn it over to Dr. Wang. I'm going to give you sharing screen privileges, and you can take it away.
Okay. Well, thank you, everybody, for attending. I'm going to start off by showing this picture here of the clinic that I work at 2 days a month. This clinic is located in the heart of Seattle's International District, and it serves a very, very diverse population. Sorry, I'm trying to advance. Okay. So it actually started off in 1973 as just a storefront by a group of volunteer health providers who noted that there really wasn't much in the way of health care for the Asian community in Seattle. That is, for people who really felt most comfortable living in this neighborhood and who did not speak English, it was difficult for them to go seek care at some of the other sites, the larger hospitals here in Seattle. And so they started just a storefront clinic with like one exam room and a very small waiting area. And then since this clinic has expanded greatly to the point that it now consists of 4 different buildings offering really wraparound services, including the services listed here, medical, dental, but also acupuncture and Eastern medicine. There are vision services. Patients can get their labs drawn there. There's a mobile mammogram van that comes by. There are pharmacists that serve the population as well. And I should also mention that there are behavioral health services for this population also. So I typically ride my bike to clinic, particularly during the pandemic. When the streets were empty, I was doing that. And so I snapped these pictures here from the International District, really right after some of the larger Black Lives Matters rallies, just to show how the community came together around that cause. These are some of the demographics from our clinic. In the upper left, you can see that 7 out of 10 of our patients are considered to be low income, with the vast majority also considered to be persons of color. It's actually a relatively young population, which may surprise you. So 1 out of 5 is 65 and over. And we also serve undomiciled patients. This was the population served back in, I think this is 2019 data. And you can see that a large percentage of our patients are on Medicaid. There are 50 plus languages spoken by our patient population, and we have in-house interpreters in some languages, and then we definitely use computer-assisted interpretation for many of our patients. But I would say that the great majority of our patient interactions occur in a different language other than English. We also have a very high prevalence of chronic hepatitis B. So this slide here shows a snapshot that was taken back between 2013 and 2015. You can see that most of the patients were Chinese, but there were other Asian ethnicities represented as well. And the prevalence was quite high, about 7% in the Chinese and Vietnamese population, actually even higher in our Somali population, and then 8% in our Mien population. I should mention that we have a very large East African population here in Seattle. That may not be well known, but you can get great Ethiopian food here in Seattle. We have many people from Ethiopia and many from Somalia as well. And as you can see, the prevalence of hepatitis B is high in that population also. So I know that this audience is very familiar with some of the barriers to hepatitis B immunization, so I won't dwell, but I will just say that some of the things that we were dealing with in our clinic is that, of course, this is a multiple shot series. We would love to have just the one shot for hepatitis B. It would make everybody's job so much easier, but it's a multiple shot series, so getting to series completion is a real challenge. As I showed you, our population is actually quite young, so many of them are recent immigrants to the United States. And as you can imagine, if you are a recent immigrant to a different country, you have competing priorities. You've got to get your kids to school, you've got to get a job, you've got to find a place to live, you've got to buy a car. You have a lot of things going on. And so hepatitis B immunization is probably not at the top of your list. And so it's difficult when patients come in and they have all these issues that they're dealing with that we're trying to help them with to then say, oh, and by the way, you also need a hepatitis B shot. And then lack of follow-up. These are busy folks. Many of them are working 2 jobs, have young families. And so, getting in for an annual visit when they otherwise feel well is difficult. And so often what we do is we see them when they, think they broke their toe or when they have a rash. So for an acute visit, and somewhere in that acute visit, we also have to remember to ask about vaccinations and to vaccinate when able. So the project I'm going to describe addresses that problem a little bit. The good news is there are a couple of things that we don't have as barriers. So one is lack of awareness among the providers. So because our providers serve such a diverse population, there's a huge amount of awareness about hepatitis B and the need to screen and the need to vaccinate and the need to screen for liver cancer. So while that may be a barrier at many clinics where there is not such a high prevalence of hepatitis B is very much on our clinic's radar. So that, fortunately, not a barrier. Cost, also not a barrier, surprisingly. I think that's the first time that I've ever put cost as not a barrier in any talk that I've given. But in this case, because many of our patients are on Medicaid, their hepatitis B vaccination is covered and screening is covered as well. We do have a little bit of difficulty with our uninsured population for the hepatitis B screening piece, and I'll talk about that a little bit more further on as well. So the rest of this talk is going to describe a project that we worked on through a grant from the CDC, and that was published in the Journal of Healthcare for the Poor and Underserved in 2018. And so this was a 2-year project that I worked on with APCHO. And it's not just me, of course. In fact, it was a team effort. but I'm just lucky enough to get to present the data today. So the goal was to determine the effectiveness of the electronic health medical record in a community health center environment to improve hepatitis B screening and vaccination. And our approach was a community engaged research framework, which means that we stopped at multiple points throughout the project to solicit input both from the patient community as well as from the clinic staff through structured interviews so that we could be sure that we were not operating in a silo or ivory tower, and that what we designed would actually be accepted by the population that we were trying to work with. And the setting was the 4 primary care clinics that I described to you earlier. So what is the electronic health record? I think we're all familiar with that. And if you are a person who sees patients, then I can guarantee that you probably have a love-hate relationship with your EHR, as we fondly call it. And I think if you were to give most providers a couple of beers, they could probably wax on for quite some time about how much they hate their EHR, because it is something that makes our lives easier and makes our lives more difficult at the same time. So in terms of positives, clearly the EHR is a powerful tool, making notes and lab results and so forth readily available, whereas I'm old enough to remember back when we just used paper charts and we had to go looking for these things. And as a medical student, I spent a lot of time running to the lab, physically running to the lab, trying to get lab results that would be given to me on pieces of paper that I would then have to run back to my intern. And so now we don't have to do any of that. It's all available at the touch of our fingertips. So that's great. And it's also easy for providers to communicate with each other. We don't have to pick up the phone anymore or try to reach somebody, play phone tag. We could just send a message in the EHR. Data are easily shared. And so there's a real potential to streamline provider workflow. On the other hand, there are negatives. Because of the EHR and how, quote, easy, unquote, it's supposed to be, there's much more documentation that's required. So it used to be that we would just write in the chart, patient's doing well, we talked about his headache, no serious causes, prescribed Tylenol, and that would be it, just a 4-line note. And now we have a whole structured note that we have to put in based on insurance requirements. There can be documentation errors. There have been some hilarious ones I could give a whole talk on hilarious documentation errors, which come from cut and paste. Usability issues, just way too many clicks to get a single task done, and then pop-up fatigue. So what is pop-up fatigue? We all like to think, oh, well, my issue is really important. For example, mammograms, really important. And so we want to pop a pop-up, remind the provider who's going to go see this patient because they think they have COVID, that the patient also needs a mammogram, and that'll appear as a pop-up. And so it's a great idea if there's only one, but unfortunately there tend to be multiple pop-ups because there are multiple things that providers need to be reminded about. And then there can be pop-up fatigue. And I know myself, I've been guilty of this in my daily workflow, getting a bunch of pop-ups and just clicking through them because you're trying to place an order, for the COVID test, and instead you've got to go through all these other reminders, and you don't even look at them. And so that's the downfall of the pop-up, is that there can be so many that they become sort of just a nuisance and not effective. So our goal was to look at this EHR and see if we could use some of the positive aspects of it, and while not harnessing some of the more negative aspects of it and driving our providers even more crazy. So putting yourself in the shoes of a primary care provider for a moment. So the backbone of these clinics really are the primary care providers, who are often or usually family practice providers, nurse practitioners, physician's assistants, so people who are trained to see a whole variety of medical problems. I'm a specialist, so I see just the one, so it's easier for me to focus. But it's difficult when you have just a variety of things, not to mention social issues and so forth that need to be addressed. And of course, providers are people, so they have family responsibilities. Maybe they're trying to call their kid's teacher or figure out if their kid was able to get on for their Zoom class and so forth. There's time pressure at our clinic. Providers are seeing about 20 patients per day, so about 15, 20 minutes per patient, keeping in mind that everything you say has to go through an interpreter, so double the time. It can be a chaotic environment. These clinics never have enough room, you always got to have a bunch of people working in the room together, lots of talking going on, phones ringing, so forth. The provider has very little control of the pace. A patient may be added on at the last minute, just when you thought you were going to go have lunch. And so there's that frustration. And then, as I mentioned, there is also the frustration of the EHR. So when we surveyed our clinic staff through one of these structured interviews that I talked about, and we surveyed everybody, so the receptionists, the medical assistants, the nurses, the providers, a few things came up as common themes. One was that it was felt that rather than just dumping this onto the provider as yet another task, that a team-based approach would be helpful. So really utilizing the entire structure of the care team. It was felt that it would be best to integrate the intervention into the clinic workflow. So not to add on something new, but to have it integrated into the workflow that was already occurring. And that would therefore also mean that it could be sustainable, that it could last after the grant, the 2-year grant, was over. Because what we didn't want was to have some great shiny new toy that lasted while we had the funding. And then when the funding was completed, then we would go back to the way we were. And then also we heard over and over again that EHR alerts were not the way to go. So I've talked a lot about the negatives of the EHR, but there's a huge positive, which I haven't mentioned, which is really the positive of data mining. So on the backside, if you have very good IT people, medical informatics people, because everything is put into the EHR, you can extract that data in a way that we couldn't before. It used to be that we'd have to get a pile of paper charts and kind of search through and have a little spreadsheet where we manually extracted data, which was very time consuming and prone to error. But here we can, with the properly written code, extract a lot of data and have it available for analysis. And so that's what we did with this project. And really one of the things I walked away from this project with was the idea that one of the best things about the EHR is the ability to get information out of it. So we looked at demographic data, so we extracted that, as well as clinical data with labs and vaccination history and whether or not hepatitis B was on the problem list. And then we used this data, we kind of compiled it to then identify people who needed to be screened for hepatitis B and those who needed to be vaccinated. And so the first challenge we had was identifying the at-risk population. Although the ICHS serves a diverse population, and so it's not that everybody who seeks medical care at ICHS needs to be screened for hepatitis B or vaccinated. So we really wanted to identify the at-risk population. And so we first asked the EHR to pick out by race, but then this didn't work so well other than the Asian races because we, as I mentioned, have a very large sub-Saharan African population, but there wasn't really, the EHR didn't really identify whether they were African born or African American, and we wanted to be able to separate that. There were many people who described mixed race, and so that EHR would not be able to pick that up through the race variable. And so therefore we went with a second variable, ethnicity, and a third one, language. And this was a powerful tool because we collect information, we have to use interpreters, so we collect information about what the primary language is. We could then identify whether the language was from an area with a high hepatitis B prevalence, one of the sort of hyperprevalent areas, and then also identify those patients to be members of our target population. Once we had these information, we then wanted to divide the patients into already immune and vaccinated, or needing vaccine, or needing to be tested for hepatitis B. So really those categories. Do nothing, already done. This patient needs to be vaccinated, or this patient needs to be screened for hepatitis B. And then we presented those information in two forms. One was on the provider dashboard, and a second was on a Huddle Sheet, and I'll describe those a little bit more. So the provider dashboard looks like this, and this is just an example with provider X, Y, A, and B. So each provider would get their own, and then they would also see the clinic summary of providers, and it creates maybe a little bit of competition, hopefully not too much, but you know, our providers tend to be type A and tend to be a little bit competitive, so it does introduce that aspect into it. And then we would then provide information as to whether the patient has been unscreened or is non-immune or has chronic hepatitis B or so forth. And the providers could review their dashboard sort of in flow, or let's say at the beginning or end of a clinic week, and then they would get paper printouts about once per month. This particular process sort of latched onto the chronic disease model. There are many chronic diseases within our clinic, primarily diabetes being the main one, that requires a chronic disease model for management. And so this was then integrated into reports that the providers were already receiving for the other chronic diseases that they were managing. So importantly, it was not a new activity that was occurring, but was simply one of many chronic diseases that now would show up on the provider dashboard and be provided in terms of paper reports. The Huddle Sheet, this is an example here. So the Huddle Sheet is something that the provider and the medical assistant would review together at the beginning of every half day of clinic, just to say you've got these patients coming in, so-and-so hasn't had a mammogram in 3 years, so-and-so needs their hepatitis B shot, and sort of in real time, so it's fresh on the provider's mind. And importantly, this can be done even without the provider and just by the medical assistant who's rooming the patient to remind the patient that these things need to be done. And so we were then able to use multiple levels of the care team and do things in real time, because as I mentioned, providers have so much going on and there are so many competing priorities for their attention that reminding them at the beginning of the week or once a month, what we felt would not be as useful as real-time reminders in flow. And they would have this Huddle Sheet to refer to, again, not just for hepatitis B, but for other aspects of the patient's medical care as well. So our results showed that hepatitis B screening and vaccination rates improved after the intervention. And so this table here looks at hepatitis B screening rates compared to with the intervention period compared to baseline. And so this first shows an improvement with the intervention. And then separate from that, in the multivariate model, there were other aspects, other factors that were that led people to be more likely to be screened. A younger age, being male, being Vietnamese. And while we can't explain all of these findings, I would say that it probably is related to the fact that many of our older folks had already been screened elsewhere, and that was not in our medical record. Same with the gender relationship. I think many of our women had been screened in the context of pregnancy, perhaps by their OB, and so that was not in the medical record, and I think that's why we saw these. But you will see that being insured was definitely related to saying yes to being screened, because while patients may not have to pay for their vaccine, those who are uninsured would have to pay for their testing, and so would likely decline testing in that setting. These are the data for vaccination, and they look very similar. Again, the intervention proved to be effective in terms of increasing vaccination rates, which I should say prior to our intervention were actually quite low. Not so much vaccination rates, but vaccine completion rates because of the three-shot nature of this. And really, insurance was again associated, male gender. And then the clinic site, and importantly, clinic site B had one of our provider champions who knew a lot about the EHR and sort of was involved with the design of the EHR and how it was implemented at ICHS. And I think that having a provider champion is very helpful. The EHR doesn't do all the work. So this slide here shows just graphically the increase in rate of screening before and after. We called our intervention HIT B, or Health Information Technology B, before and after the intervention. And then similarly, this is for the vaccination rates. And so as I mentioned, you can see that our first dose even rate was quite low, about 30% prior to the intervention, and went up to about 60% after the intervention. So in terms of how to eliminate hepatitis B in the United States, I grabbed this off the report that was published by the National Academies of Sciences, just to show with the red star here that of the multiple interventions that are listed, one of the things that's pointed out is that much of the burden for managing chronic Hep B falls on overworked primary care providers. And I cannot sort of second that opinion more. As a specialist who goes into the clinic twice a month, I am in a privileged position, but I see how hard everybody else is working. And often, actually, I feel like, how do they even manage? And so we're hopeful that a relatively easy, really paper-based intervention like ours can help to remove some of the burden while at the same time improving hepatitis B screening and vaccination rates. So in conclusion, I would say that our finding primarily was that the EHR was most useful in extracting data to point out to identify who needed to be screened and who needed to be vaccinated for hepatitis B. And then after that, actually, it was a much simpler solution, not an EHR-based pop-up, but really a paper-based solution with a Huddle Sheet utilizing multiple levels of the care team to remove some of the burden from the primary care providers. I think I made that point there. So that is actually the end of my presentation, and I'd be happy to take any questions.
Wonderful. Thank you so much. That was a really great presentation, and I think you made some really important points. I think we hear all the time about potentially incorporating EHR reminders, and I think you make a great point that our providers, especially at the primary care level, are burdened, and making sure that we're acknowledging that and trying to work with the system as seamlessly as possible into these existing workflows is so important. I'd like to invite those of you who attended today to share any questions or comments you might have for Dr. Wang at this time. And I do have a couple of questions for you. For somebody who might be just starting into the hepatitis B space, or a new physician going into family medicine, what advice might you have if they wanted to take up a similar initiative, starting from the beginning? What tools did you have that were really essential to making this a success in your clinic?
I would say that having been a physician now for more than 30 years and working with physicians all the time, I see that a common mistake that we make is that we take all the burden onto ourselves. In other words, I think we're very we're people who tend to be rather type A, who sort of feel like if you want it done right, do it yourself. And I actually feel like that is often a counterproductive attitude, and that delegation is important because there's always so much that one person can do. So I would say to a primary care provider, family practice provider starting out, that that what they do is so difficult and so important, but they really need to look at all the members of their care team. For everyone, there's a nurse, there's a medical assistant. There often are people who manage referrals and people who manage medical records, and then the informatics folks. So look at all the levels of that care team to try and just spread the work out a little bit so that it doesn't always rely on one person.
Great, thank you. And we do have a couple of questions from the audience. The first question, how replicable do you think your intervention is in a variety of communities? And also, can we reach out for your information and get more details, or potentially share this publication if individuals are trying to replicate it elsewhere in the U.S.?
So the second part of that, I would say yes, of course. The whole purpose of this study was to try to produce something that could be disseminated, and I would be happy to help in any way that I can. In terms of, I'm sorry, what was the first part of the question again?
Yeah, it was just about replication and how replicable you think this intervention might be in a variety of communities or different settings.
Yeah, so I think the concept of the Huddle Sheet is obviously easily replicated, really just sort of a touching base. It's just a touching base between the provider and the provider's assistant at the beginning of clinic, just to bring things to the forefront in terms of remembering to do things for certain patients. The part that might not be as easily replicated is the informatics piece. We are lucky at ICHS that we have a very strong informatics team. And I know from my other hat, by the other larger hospital where I work, we often reach out to the informatics team to try and find, get information from us. That's not something that I could do myself. You know, it involves writing code and really being familiar with sort of the back end of the EHR. And so we use that team up front to find us our target population. Without that, this intervention would not have been as effective. We still could have done it, but it would have been very much diluted because we would have been looking at people who didn't necessarily need to be screened or vaccinated for hepatitis B. I mean, one could argue that everybody needs to be vaccinated for hepatitis B, but in terms of the target population from the high endemic regions that we were looking at. So just the short answer is it depends on how good your informatics team is.
Definitely. Thank you so much. Another question, are you using Heplusav B for vaccination? And if so, have you found this to improve completion rates at the 2 doses versus the 3-dose series?
So we haven't looked at it systematically, but it's definitely my impression that that the completion rates are much better. I mean, it's just easier to remember 2 shots, particularly within a shorter time frame. Our issues have been with supply and also insurance coverage. And maybe somebody on the call knows better than I actually whether Medicaid covers the Heplusav, because I've mostly have used it in privately insured patients in the other clinic setting that I work at.
Yeah, that's a great question. My understanding is it may depend on the state, but yeah, maybe someone else on the line might be able to know, or that's something we could certainly look into further. But I believe there is some level of coverage.
I also think that's a great option for people who don't respond to the initial series, because it's a different form of vaccination with an adjuvant. And so, you know, theoretically, it might work for the 10% of people who don't respond to the more traditional 3-shot hepatitis B series.
Definitely. Yeah, and I just got a note in from, and it's just saying that, yes, it depends on the traditional versus expanded Medicaid plan for coverage there. Yeah. Let's see, I got another question. One individual just mentioned that Heplusav B has excellent coverage in Medicare, Medicaid, and private insurances as well. Thank you for that comment. Another question, was there anything that surprised you as you were doing this study that might be relevant to somebody who's considering doing something similar?
Yeah, to be honest, we didn't think about the Huddle Sheet at the beginning. This is something that really came up during one of our structured interviews with the clinic staff, because it seemed like such a simple thing, too simple. we were thinking way more complicated. Initially, actually, my first conceptualization was an EHR pop-up. I feel like that's where our brains always go. And so I was surprised at something so simple. I was, first of all, surprised to find out how much people loathe the pop-ups. That was, I thought it was just me. I didn't realize that everybody else felt the same way. So that was good to know. And then the second part being that something so simple, which really just is people talking to each other. We sometimes forget with the EHR, we're always messaging each other, but sometimes talking is good too. Could be as effective as it was.
Yeah, definitely. So it sounds like key takeaways are, trying to think about strategies like the Huddle Sheets or including them in reports to seamlessly integrate this, potentially avoiding those pop-ups because there's so many of them. And I think there's like fatigue associated with all the pop-ups that providers get. So it might not be effective in that way. But yeah, you're totally right. I feel like that's where all of our brains go, is like, how can we make it easy? And the pop-ups is always something that pops up for sure. Great. Well, I do not see any other questions in the comment or question box. So I wanted to just thank you so much for presenting in your time today. This was an excellent review of a strategy that could be definitely applicable, I think, and replicable in a variety of situations, particularly our FQHCs. So thank you so much for your time and in your presentation, Dr. Wang. We really thank you so much for your work as well in this initiative. And we'll be sure to share a recording of your presentations after the session to everyone who attended and registered as well for later viewing. So thank you so much.
Well, thank you. It was my honor.
Thank you. Yeah, this is great. And I just want to point out for our attendees today, this month is on, I think, April 30th is National Adult Hepatitis B Vaccination Day. So on April 29th, we are having a briefing, which the flyer for that briefing is listed on this slide here that you're viewing. And you can register in the chat box. The Zoom link was just posted to register for this briefing. And you can see we have a great esteemed list of speakers that will be talking about the importance of adult hepatitis B vaccination in honor of Adult Vaccine Day, which is April 30th. And that's really why we're focusing on vaccines this month. Really, we should definitely use all the tools that we have to address hepatitis B through prevention, and vaccine is certainly one of the best tools that we have out there. So thank you all. If you have any questions, feel free to reach out to us at the email listed here, and we look forward to seeing you all on April 29th.
Thank you. Bye.
Bye. Thank you.